Imagine you have this persistent low-grade physical pain that just will not go away. Like you go to the doctor, you take all the tests, and they look at the results and say the words you thought you wanted to hear, which is, good news, the initial infection is completely cured.
Right, which sounds great on paper.
Exactly. It sounds great. But you're sitting there still in pain thinking, well, if I'm cured, why does it still hurt so much? What if the source of your pain isn't just in your nerves, but is actually like the lingering echo of a microscopic, multi-species bacterial fortress that had basically set up camp inside you?
It's it really is a profound shift in how we understand chronic discomfort.
Hmm.
And it's exactly what we're seeing in the latest medical research right now.
Yeah.
Because to truly understand this chronic pain loop, we kind of have to look past the symptoms and dive into the actual microscopic ecology where it all begins.
Yeah, and today we are looking at a stack of sources that, honestly, they challenge everything we thought we knew about treating localized pain and infection. We've got the European and UK guidelines on the management of vaginal conditions, alongside some incredibly detailed research from Frontiers in Cellular and Infection Microbiology and Science Translational Medicine.
Which are fantastic sources, by the way. Very comprehensive.
Yeah, really dense, but so fascinating. And our mission today is to explore one very specific question. Can a chronic biofilm, composed of mixed bacterial species on the vaginal wall, maintain a low-grade inflammatory state that actively prevents pain recovery?
And I just have to say, it is a phenomenal question because it forces us to abandon that traditional binary view of infections.
Yeah.
We're so used to the idea that you either have a pathogen actively multiplying in your body or you are healthy. There's no in between.
Right, like an on-off switch.
Exactly. But the reality of the vaginal microbiome is fundamentally about ecology. It's about balance and territory and, resource management.
Okay, so to understand how that ecology breaks down, we should probably establish what a healthy, balanced state actually looks like, right? Like, what's the baseline?
Yeah, so in the scientific literature, researchers categorize the vaginal microbiome into what they call community state types. And when we look at a really robust, highly protective state, it is almost always dominated by a specific bacterial species called Lactobacillus crispatus.
Crispus, okay.
Yeah. You can think of L. crispatus as like the ultimate keystone species of this environment. It produces a compound called D-lactate. It generates hydrogen peroxide, and it secretes these antimicrobial proteins.
Wait, hydrogen peroxide? So it's essentially manufacturing its own natural disinfectant.
Precisely. Yeah, all of those secretions work together to keep the vaginal environment highly acidic, usually at a pH around 4. And that high acidity is just incredibly hostile to outside invaders. Most environmental pathogens, they simply cannot survive in a space that acidic, like their cell walls literally degrade.
Oh, wow. Okay, that makes total sense. It's a hostile environment for invaders, but a super healthy one for the host. But the research points out that this ecosystem is, well, it's fragile. Our sources focus heavily on what happens when things shift toward a different bacteria, one called Lactobacillus in murdeners. And this is where the vulnerability really starts, right?
Yeah, that shift is where the foundation starts to crack. Now, L. eners is still a lactobacillus, so historically, doctors seeing it on a test might just assume, oh, everything is fine. But it behaves very differently from its cousin crispatus.
How so?
Well, for one, its entire genetic code is unusually small. It literally lacks the genetic blueprints to manufacture the high levels of D-lactate and all those protective chemicals we just talked about.
Okay, let's unpack this. So it's occupying the space, but it's not actually defending it.
Exactly. But what it lacks in defensive capability, it kind of makes up for in sheer resilience. It is highly adaptable to stress. So if the environment experiences a massive disruption, like, say, a systemic round of antibiotics or significant hormonal fluctuations, L. crispatus might completely die off, but L. eners survives.
I see. It's like a squatter who survives a hurricane. Like, they won't fix the roof, but they refuse to leave.
That is a perfect analogy.
But if L. eners is technically a lactobacillus, why does its survival actually set the stage for chronic issues? Like, it leaves the whole hillside vulnerable to erosion, basically.
Right. Because L. eners is so resilient but so poorly equipped to defend the space, it creates this transient or unstable microbiota. Now, in some healthy women, this is just a temporary phase and the ecosystem eventually resets. But in women suffering from chronic vulvovaginal discomfort, or CVD, this L. eners state becomes the stubborn baseline reality. The squatter holds onto the territory, but their lack of chemical defense leaves the door just wide open for opportunistic invaders.
Which brings us to the primary villain in our sources, which is Gardnerella vaginalis. This is the bacteria that kicks off bacterial vaginosis. But From what I read, it doesn't just, like, float around causing a standard infection. It actively dismantles the host's natural defenses. The research details this whole process where Gardnerella, along with Prevotella bivia, produces an enzyme called sialidase.
Yes, sialidase.
How does that enzyme actually help them take over?
So sialidase is essentially a biological tool used for structural demolition. The vaginal wall is protected by a natural layer of mucus, right? And that mucus is basically a dense mesh of proteins, and at the very end of those protein chains are sugar molecules called sialic acids. Sialidase acts like chemical scissors. It just snips off those protective sugars.
And the bacteria use those sugars for food, right? Like they're eating the barrier.
They do, yeah. It's a great nutrient source for them. But the devastating side effect for the host is that by snipping off those sugars, the enzyme literally degrades the structural integrity of mucus layer. The protective barrier completely dissolves, and that exposes the vulnerable human tissue underneath.
Man, so the shield is totally down. Once that bare tissue is exposed, how does the actual biofilm form? Like, how do they build the fortress?
Well, once the land is cleared, Gardnerella vaginalis acts as the master builder. It has this really unique ability to anchor itself directly to the underlying human epithelial cells. So it lays the foundation. And once it establishes that biological scaffold, it allows other secondary bacteria to latch on, species that could never have attached to that slippery mucus on their own.
Right, and the sources mention Atopobium vaginae as one of those secondary colonizers.
Yes. Atopobium vaginae is a strict anaerobe, which means it thrives in environments that are completely devoid of oxygen. So deep inside a layered bacterial structure is like the absolute perfect environment for it. Together, these mixed species excrete this sticky protective matrix. They build a highly structured polymicrobial biofilm directly over the human tissue.
It's like a rogue construction crew. First, they bulldoze the natural forest, the mucus, and then they pour concrete to build this microscopic bunker. It shields them from the host's immune system, and it keeps out whatever lingering lactic acid the good bacteria might still be trying to produce.
Exactly.
But the most fascinating, and maybe the most insidious part of this, is how Gardnerella behaves once it's safely inside that bunker, because it doesn't just rapidly multiply and attack, does it?
No, it doesn't, and that is its brilliant evolutionary strategy. Once the biofilm is established, Gardnerella vaginalis actually decreases its own metabolic activity. It slows down. And crucially, it also intentionally downregulates a specific virulence factor it produces called vaginolysin.
Vaginal what is that?
Vaginolysin is a protein toxin that essentially punches holes in human cells. It's very destructive. So by dialing back the production of that toxin, the bacteria essentially go into stealth mode. By lowering its profile, it ensures long-term persistence rather than a quick, easily detectable infection.
Wait, okay, if they are in stealth mode and dialing back the toxins, how does the body ever know they are there? The tissue must be signaling for help somehow, right? This leads into the whole immune response part of the research, which I found incredibly counterintuitive.
Oh, it is deeply counterintuitive. To understand how the biofilm manipulates the body, we really have to look at how our immune system chooses its weapons. So when a patient has a severe acute infection, say a massive influx of rapidly dividing bacteria, the body responds by deploying type 1T helper cells, or Th1 cells.
And those are the aggressive ones, right?
Right. Th1 cells are the body's search and destroy mode. They trigger a flood of inflammatory cytokines, they activate macrophages to physically go in and eat the bacteria, and they clear the infection. But that aggressive response is what causes noticeable acute symptoms, like severe swelling, intense redness, sharp pain.
Right, that's the raging fire alarm. You definitely know you have an infection.
Exactly. But the biofilm doesn't want that alarm to go off. So in this state of chronic intermediate dysbiosis, the biofilm somehow tricks the immune system into deploying type 2T helper cells, or Th2 cells instead.
Okay, and what do Th2 cells do?
Well, Th2 cells are typically responsible for managing parasites or, more importantly here, initiating tissue repair and producing antibodies. They actually produce anti-inflammatory molecules, specifically interleukins like IL-5 and IL-13. This Th2 response actively inhibits the aggressive cell-mediated immunity. It essentially calls off the search and destroy macrophages.
Okay, wait, here's where it gets really interesting. Because if the biofilm is actively triggering an anti-inflammatory response and calling off the aggressive immune cells, why are we talking about a low-grade inflammatory state that causes pain? Shouldn't anti-inflammatory mean less pain?
Right. That is the exact paradox that leaves so many patients frustrated and, frankly, misdiagnosed. The Th2 response does systemic damage control. It stops the massive, raging fire that would normally clear the bacteria out completely, and that allows the biofilm to survive asymptomatically under the radar.
Okay.
But, and this is the critical so what of the research, while the systemic clearing mechanism is suppressed, the bacteria inside the biofilm are still naturally shedding outer membrane fragments. They are still releasing localized endotoxins directly onto the raw exposed vaginal wall.
Oh, I see.
Yeah, and this localized endotoxin release triggers higher quantities of cytokines and prostaglandins right at the vaginal wall. As a result is a really confusing mixed signal.
Okay, so let me try an analogy here. It's kind of like someone cutting the wires to a house's main smoke detector. The fire department doesn't hear the alarm, so they never show up with the heavy hoses to actually put out the blaze. But locally, right there in the kitchen, a small fire is still slowly burning the cabinets.
That is exactly what is happening. The systemic alarm is silenced. But locally, those endotoxins are triggering a very specific, smoldering, low-grade inflammatory state at the tissue level, and the immune system is blocked from fully putting it out.
Which perfectly answers our central question. Yes, this mixed species biofilm absolutely maintains a low-grade inflammatory state. But let's bring this back to the listener. What does that slow chemical burn actually feel like over time? The sources mention things like chronic vulvovaginal discomfort and provoked vulvodynia.
Yeah, it leads to a pretty tragic clinical timeline. Because when tissue is constantly subjected to that slow burn of localized inflammation for months or even years, it physically changes. Let's say a patient is finally diagnosed and a doctor treats the infection with standard meds. The lab results start to look good. The white blood cell count normalizes. The healthy lactobacillus may even start to return and correct the pH.
So by all standard microbiological metrics, the patient is supposedly cured.
Right. But the clinical reality from the texts shows that dyspareunia, which is severe pain during intercourse or physical contact, is the very last symptom to resolve. Sometimes it takes weeks or even months after the bacteria are seemingly gone.
Wow. But why is the tissue still hurting if the fire is finally out?
Because of the ultimate neurological consequence of that localized inflammation, the constant presence of those inflammatory prostaglandins doesn't just damage the surface cells, it fundamentally alters the peripheral nerve receptors embedded in that tissue. It causes a phenomenon related to synaptic plasticity.
Wait, it changes the nerves themselves.
Yes. The nerves are continuously irritated for so long that their threshold for firing drops dramatically.
So they become hypersensitive.
Exactly. It creates a learned response to pain in the pelvic floor. The receptors that normally only detect a light, harmless touch become chemically rewired to signal severe pain. Even after the biofilm is eradicated, those nerves are still stuck in a hyperexcitable state.
That is a staggering realization. Like, the biofilm doesn't just damage the tissue, it literally rewires the nervous system. The bacteria might eventually be cleared out, the bunker might be demolished, but they leave behind this phantom alarm system. The nerves are just firing pain signals, even though the original threat is long gone.
And that biological reality completely changes how we have to approach treatment, because you cannot treat a neurological phantom alarm with an antibiotic.
Right, that makes no sense.
Exactly. This is why patients suffering from severe chronic discomfort often find themselves prescribed central nervous system agents. The texts detail the use of drugs like gabapentin, which specifically targets nerve pain, along with tricyclic antidepressants and intensive pelvic floor physical therapy. These therapies aren't fighting a pathogen. They are necessary interventions to help the nervous system unlearn the pain response that the biofilm originally initiated.
It totally shifts the paradigm from treating an active infection to managing a neurological condition. But if we want to prevent that rewiring from happening in the first place, we have to actually destroy the biofilm early on. And the research highlights a pretty grim statistic about our standard weapons. Standard antibiotic therapy for BV has an estimated relapse rate of 50% at 6 months.
Yeah, it is basically a coin flip on whether a patient will be sick again in half a year.
Why do traditional antibiotics fail so often here? Because they clearly don't break the fortress.
Right. It comes down to the architecture of the biofilm we discussed earlier. Standard antibiotics are highly effective at killing planktonic bacteria, which are the free-floating cells outside the biofilm. So when a patient takes the antibiotic, those free-floating cells die off, which temporarily halts that localized inflammation, and the symptoms ease up. The patient feels better.
But the bunker is still there.
Exactly. The sticky matrix of the biofilm is incredibly difficult for standard antibiotics to penetrate. So the Gardnerella cells deep inside the scaffold, they just survive the treatment. As soon as the antibiotic course is finished, those surviving bacteria just ramp their metabolism back up and start rebuilding the population. And the cycle just starts all over again.
So we need something that doesn't just kill the free-floating bacteria, but actually, like, breaks the concrete and reclaims the territory. The research pointed to some fascinating new therapeutics on the horizon, specifically biofilm disrupting agents. Can you explain the approach they used in the trial with lactin V?
Sure, yeah. Lactin V represents a huge shift toward ecological restoration. It recently went through a phase 2b clinical trial. Essentially, it is a vaginally administered therapeutic made of lyophilized, which just means carefully freeze-dried Lactobacillus crispatus CTV-05.
So they take that keystone species, the ultimate protector we talked about at the beginning, freeze dry it so it survives in a powdered form, and then deliver it directly to the site.
Correct. The strategy in the trial was to use an antibiotic gel first to knock down as much of the pathogen population as possible, and then immediately follow with the lactin V applicator. You flood the zone with a highly robust strain of the protective bacteria. The goal is for the L. crispatus to rapidly colonize the bare tissue, drop the pH, and hold the territory before the surviving Gardnerella can rebuild the biofilm. And the trial actually showed remarkably lower recurrence rates compared to just using antibiotics alone.
That makes total sense. You clear out the weeds and you immediately plant a deep-rooted tree so the weeds can't come back. But the sources also mention an even more radical approach for patients where even that doesn't work, vaginal microbiota transplantation, or VMT. I have to admit, when I was reading the exploratory research on this, taking bacterial fluid from a donor and transplanting it into a patient, it sounds kind of extreme, maybe even a little risky. Is this actually safe?
Well, it is a completely natural reaction to find the concept jarring at first.
Mm-hmm.
But the logic is actually rooted in a highly successful treatment we already use in gastroenterology, which is fecal microbiota transplants for severe, life-threatening C. diff infections in the gut.
Oh, right. I've heard of that.
Yeah, so the principle is exactly the same. For patients with intractable bacterial vaginosis, meaning they have tried every antibiotic, every probiotic, and nothing breaks the cycle, researchers are exploring VMT.
How does it actually work in practice? Like, what is the procedure?
They rigorously screen a healthy donor who has an optimal Lactobacillus-dominated microbiome. They take a fluid sample, process it, and transplant it directly into the patient. And the early exploratory results are incredibly compelling. In one small study of 5 patients with severe, uncurable BV, 4 of them experienced long-lasting relief, ranging from 5 to 21 months after a VMT procedure.
Wait, really? Up to nearly 2 years of relief for a condition that was previously uncurable?
Yes. It strongly suggests that when the ecosystem is so profoundly degraded and the biofilm is so deeply entrenched, you can't just kill the bad actors. You have to completely replace the entire microecology of the space.
Which really makes you wonder about the future of treatment. Could the standard of care shift entirely from, killing the bad guys to replanting the forest? It seems like that's the only overarching theme of these papers that actually works. We're moving away from simply exterminating bacteria toward complex ecological management.
We have to. I mean, the 50% failure rate of antibiotics proves that ignoring the structural reality of the biofilm is a dead end. We have to disrupt the physical scaffold, neutralize that localized inflammation, and deliberately reseed the environment.
So let's look back at the core mission of this deep dive. We asked if a mixed species biofilm could maintain a low-grade inflammatory state that actively prevents pain recovery. And the mechanisms we've explored today show exactly how it happens. Gardnerella bulldozes the protective mucus using sialidase. It anchors to the tissue and builds a bunker with other bacteria.
Right, and then it goes into stealth mode.
Exactly. It tricks the systemic immune system into an anti-inflammatory repair mode, all while shedding endotoxins that cause a slow chemical burn locally.
And that slow burn is what ultimately rewires the peripheral nerves, dropping their threshold for pain and creating a learned neurological response that basically torments the patient long after the initial infection is cleared.
It's an incredible, albeit slightly terrifying, chain of events. A microscopic ecological collapse that ultimately ends in a physically rewired nervous system.
It really is. And that biological reality leaves us with a profound concept to consider. Because if a localized microscopic biofilm can effectively train your nervous system to anticipate and feel pain months or even years after the bacteria have been eradicated, it fundamentally changes how we view chronic conditions overall. It raises an important question. How many other chronic unexplained pain syndromes in the human body, conditions we currently treat as mysteries of the nervous system, are actually just neurological echoes left behind by long-gone microbial fortresses?
Are the mystery illnesses of today just the ghosts of the biofilms of yesterday? That is a wild thought to leave on. We started this exploration talking about the expectation of a clean cure, the broken arm on the x-ray, the clear lab test. But as the research shows, the intersection of chronic pain and microscopic ecology is vastly more complex. It's a world of stealth survival, chemical manipulation, and phantom alarms. Thank you so much for taking the time to explore this incredibly important topic with us. Keep asking questions, keep challenging the standard answers, and keep exploring the invisible worlds that are actively shaping your health.